This is a really crucial topic and covers a limb-threatening emergency. If we get it wrong, we can easily be losing limbs. So that's why it's so important we understand the anatomy around it. Because it's so important, I've got lots of questions for you first off. First of all, think about what is compartment syndrome? What's the anatomical structure that causes compartment syndrome? I want to understand the pressures within the compartment that causes it. If you give me a one-word answer for the clinical features, I'd be over the moon. Understand how we treat the compartment. And then finally, how many compartments are there in the leg? Well, this is what I consider to be compartment syndrome. It's a pathological process and it's due to an increased pressure within a fascial compartment. And that causes microvascular compromise. And if it's untreated, that will lead to tissue necrosis. The term microvascular is crucial in understanding what pressures are at play in this condition. Well, the anatomical structure is the deep fascia. Remember the very first day in the dissecting room where we'd taken off the skin and the fat of those limbs, and then there's that tough layer overlying the muscles. That's the deep fascia. The function of that is to keep the muscles from bulging out when we're contracting, and that increases their efficiency. And that tough fascia can't be stretched acutely. So the deep fascia is what causes compartment syndrome because it can't expand. That deep fascia is also in continuity with the septi between large muscle groups. If you get swelling within that compartment, that fascia won't budge, and you'll get an increase in pressure within that compartment. So what pressures did you come up with? Hopefully they're fairly low. Remember in the definition that it's microvascular compromise. So therefore we only need to increase the pressure above the capillaries to stop blood flowing through them. So the pressure in the compartment to cause compartment syndrome is relatively low around capillary pressure. It's nowhere near diastolic pressure and certainly nowhere near systolic blood pressure, hence it's in really small letters.
So, remember Starling's diagram of the pressures across a capillary. The hydrostatic pressure within the capillary, i.e. the pressure within the blood in the capillary, is fairly low. That's represented by the red diagonal line going from about 40 millimeters of mercury at one end down to 15 millimeters of mercury at the other end of the capillary. So it's all fairly low. And we can test that by just looking at how little pressure it takes to compress the capillaries in our fingers. So we've seen the pressure within the capillary is low, so therefore the pressure required to compress the capillary and stop blood flowing through it is low also.
It's slightly more complicated than that, because if our diastolic pressure is low, our capillary pressure is going to be lower as well. So therefore you need a lower pressure in the compartment to compress our capillaries. And we've got this calculation called delta P, or a difference in the pressure. Because we can measure the pressures in compartments by putting needles into those and attaching those to manometers. So if you're unsure as to whether a patient's got compartment syndrome, we can measure that pressure by putting a needle into it. We can calculate the patient's delta P by taking the blood pressure and taking away the compartment pressure from the diastolic blood pressure. If a patient has a delta P of less than 30 millimeters of mercury, they have got compartment syndrome, and we need to do something about it. But the take-home message is the low pressure that causes compartment syndrome. So what are the clinical features of compartment syndrome? Well, for those of you who said pain, great, I'm delighted to hear that. I would say that the clinical features of compartment syndrome are pain. They're pain out of proportion to the injury, and they're pain on passive movements of the muscles going through that compartment. The 5 Ps. Pain, pain out of proportion, pain on passive movement. In my opinion, those are the only Ps to describe compartment syndrome. Let's think about why it's so painful. Well, these muscles have no blood coming and oxygen going into them because of the capillaries being compressed and no flow in those. So you've got the build-up of the lactic acid and the anaerobic metabolites of respiration. Imagine the worst cramp you've ever had. Imagine when you're down in the gym and you're really pushing it, you've got that ache. Well, these muscles are going through all that. It's incredibly painful. Then you come along and gently move that muscle, and it's going to make it worse and exacerbate it. So pain, remember the 5 Ps. In my opinion, these are the only Ps to describe compartment syndrome, and you'll pick it up early and save legs. I'm sure some of you have read textbooks and they've talked about these other Ps, paresthesia, paralysis and pulselessness. I'm going to talk about this very quietly because I want you to forget about them. These are really late signs of compartment syndrome. That means that nerves have died. That means that muscles have died. And pulselessness is a rubbish sign for compartment syndrome. Because remember, it's a microvascular problem. Within our compartment, we may have some big arteries going through it, but the pressure in those arteries is 120 over 80, or if the patient has lots of pain, it can be 160 over 100. So that blood's going to go straight through the compartment, no problems at all. And you'll feel the pulse on the other side of that compartment. What's going on in the compartment is that microvascular problem. So the muscle will still be dying, and you'll still be able to feel the pulse on the other side of that compartment. So pulselessness only really occurs when the whole leg's dead and you're just about to do an amputation. So it's in small letters. I'll talk about it quietly so you forget about it. Because really, those signs mean that get on the phone to the medical defence unit because somebody's cocked up and the patient's going to lose their leg. So have a look at this. Has this patient got compartment syndrome? Footballer, fit and well, closed fracture. You saw them in A&E, put them in a back slab, really comfortable. They're on the trauma list the next day for an open reduction, internal fixation, possibly an IM nail. You call in the middle of the night to see the patient, they're complaining about terrible pain. You go and see them, they're clinically sweaty, their pulse rate is at 90, their blood pressure is 140 over 95. You can feel a normal dorsalis pedis, normal posterior tibial pulses, but when you move their toe backs and forwards, they've got a lot of pain on passive extension. He's had 50 milligrams of morphine in the last 3 hours, and he really wants more. What do you do now? What do you phone a friend? So yes, they've got compartment syndrome. So what do you do now? Well, you phone a friend. You call the on-call registrar. You phone theatres to book him for fasciotomy so it can release those compartments. You call the anaesthetist and tell him it's an emergency. Then you go down to theatres to make sure it's booked. Get him down there as quickly as you can. You've got about an hour and a half, 2 hours to play with, maximum, until you start getting permanent damage. You may have been in pain for an hour before the nursing staff picked him up. Don't take no for an answer. If the reg says, oh, he's just that footballer, he's whinging, don't believe them. You are a UEA trained FY1, so you're likely to be correct. And if you miss that compartment syndrome, that patient loses their leg and their career is all over. In my mind, if you overdiagnose it, you may have a leg on your face. But personally, if you phone me in the middle of the night, I'll come in, I'll come and sort it out. If you've not made the right diagnosis, don't worry. I'll still thank you for calling me, just in case. So what are we going to do? Well, I want to get on and release those compartments so the muscles can bulge and the pressure is released. I can do that by making 2 long incisions either side of the subcutaneous border of the tibia. And I can get access to all 4 compartments in the leg because I can divide the septi between those compartments because we know that's in continuity with the deep fascia. It's important to release all 4. Don't forget the deep compartment in the posterior surface. So I hope that's been a useful talk for you, and certainly if you save at least 1 leg in your lifetime, then this last 5 minutes have been worth it. I think that's the last one in the series of the emergency surgical anatomy. I really hope it's useful, and I really hope that during your FY1 years you actually look back on these and think, oh, I remember that odd chap talking on the screen, and that was really useful. Take care then, best of luck, and look forward to seeing you as doctors.